The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon and welcome to today's presentation, Treating for Outcomes or Better Care, Understanding and Using the CCBHC Process to Manage Organizational Quality. Today's executive web briefing is brought to you by the ECHO Group and Open Minds. During our 90 minutes together, we will explore opportunities within the Excellence in Mental Health Act. Our presenter, Norris, will also provide a practical framework using the Certified Community Behavioral Health Clinic process to assist in today's exploration. Ms. Norris is celebrating 20 years with the ECHO Group and has more than 35 years experience in healthcare, including healthcare law, managed care, and behavioral health. Suki has extensive experience with Medicaid waivers, meaningful use, and the Excellence in Mental Health Act. She has worked extensively in data analysis, including analysis of big data in support of clients and ongoing research. Her knowledge of behavioral health law has been sought by customers across the country as they address specific needs such as electronic health record implementation. You may notice that all attendees have been muted. We're recording today's event and muting the phone lines ensures the highest quality of sound. We will hold a brief question and answer session at the end of the presentation. However, we do encourage you to submit questions via the question box on the GoToWebinar panel at any time throughout the presentation. Without further ado, I'll turn the floor over to Suki.
Thank you very much, Wyatt. Today we're going to talk about, as Wyatt said, the treating for outcomes. The idea being that while 24 states did planning grants, as you may know, some states didn't, and not all mental health agencies will be CCBHCs. But there is quite a lot of information within this whole process as to what folks are thinking is how quality is being defined going forward within behavioral health with behavioral health agencies. So what we're going to cover today is I'm going to do an overview of the Excellence in Mental Health Act. And then we're going to focus in and hone in on what are quality measures. We're going to review them as well as reviewing the quality measure development process. So how did those quality measures come to be? And then we're going to look at what really the focus of, are these opportunities or challenges? And then of course, as Wyatt said, we'll take questions. The Excellence in Mental Health Act was part of the Protecting Access to Medicare. It was established in one of the sections of that law, and of interest, it is really the first law that focuses expressly on behavioral health, as opposed to trying to fit behavioral health into a medical law or some other law that has to do with physical health or some chronic illness, etc. This is really a focus on specifically behavioral health. And that's really why we're taking this opportunity to take a deeper dive into it. If this is the federal government's first foray into saying how they define behavioral health, it serves our purpose to really understand that. Within Section 223, there were 6 areas that were specifically identified. One is staffing. How are the entities, these CCBHCs, supposed to be staffed? The availability and accessibility of services, the coordination of care, the scope or array of services, the quality requirements and reporting requirements, and then organizational authority. And then it was determined that these behavioral health centers that we're going to bring into the system were going to be called Certified Community Behavioral Health Clinics, or behavioral clinics. Using this, this graph that was presented by the National Council, kind of see how each of these elements, each of these areas of focus are equal, and they sort of run parallel to each other or in a circle. So not one isn't, there isn't a logical flow, there isn't specific requirements of one before the other. Each of them, sort of part of a continuous quality assurance, is always part of the core element, the core focus of CCBHCs. In the next slide, you see a bit of a definition for each of these. Education and reorganizing the workforce. This is really the concept of redefining job functions and really having a renewed focus on what are the skill sets of the folks doing the job, providing these services, expanding, as an example, peer ensuring that their peer services are made available, and also sort of redefining the relationship between the folks providing clinical service and those managing clinical service. Clinical excellence, this is a core importance here, because the idea of the CCBHC is to provide the best service, the service that's defined as being the most broad-based, the most excellent, as to really obtain the outcomes that are being sought by this project. Managing the transition is that, calculating and reporting costs is one of the biggest challenges I think many agencies who are thinking about being CBHCs found, because it's really a way of looking at costs that many agencies hadn't done before. What is the true cost of providing services? Not just the cost that you may have identified as being the service cost, but when you bring in all the other costs in your agency, the land, the desk, all of it, all of those kinds of administrative costs, and you build those into the service costs, that's really what they're looking for in terms of what is the cost of providing these services, so that when we manage the reimbursement rates, we are really reimbursing for the existence of that CCBHC, not just for the individual service that was provided. And then project managing. This isn't a single instance of, oh, I'm going to have to reform my agency to be a CCBHC, but it is the goal of the continuous quality improvement, so that there's always an eye to what have we done, what can we do to improve it, how do we keep that cycle moving forward. Strategic planning is really tied back to all of it, but specifically the calculating and reporting costs. How do you redefine your agency and the operation of your agency in a new payment model? And the CCBHCs do bring in a prospective payment model, which is something that Medicare has had in the past, but is very new to behavioral health. And then environmental readiness. Is your environment ready? Has the state done what it needs to do to empower the CCBHCs? What other kinds of things have to get done so that you are ready, you as an agency are ready to provide this array of services? And I should just take a moment to say that the array of services is quite broad, from crisis services 24/7 to focusing on veteran services and services needs specifically by veterans. So it's really across mental health and drug and alcohol, care coordination with physical health, and then a broad array of behavioral health services that are expected to be provided on a 24/7 process. Some other related items that I think are important. One of the things that's being developed by the Excellence in Mental Health Act is to implement and maintain a data-driven quality improvement plan. As we go through the quality measures, and we will, you'll see, or you may start getting a picture of how data is going to be used to ensure the quality of what's being provided and that continuous quality improvement. What have I learned from the data? What can I do to improve based on what the data is telling me? Also, the CCBHCs do provide a wide array of services, but SAMHSA and CMS wanted to make it clear that just because they didn't mention something doesn't mean that the mental health agency doesn't need to provide it. So you can't say, you can't limit the provision of services, the assessments or screenings or anything else, to just the specifics of CCBHC. You still have to provide the care that you deem is appropriate or a reasonable person might deem is appropriate. Evidence-based practice was specifically mentioned, and states, not SAMHSA, so these will be state-specific, and they can have differences as that goes on, but the states are going to be required to identify and implement a minimum state of evidence-based practice. And then, similar to meaningful use that many of you might have seen, specific mention of the use of clinical decision support and electronically transmitted prescriptions. Interesting here, in a lot of research that I've done about clinical decision support, most of the academic, if not all of the academic research, has been in the physical health world. So they're asking you to implement clinical decision support in a world where there isn't a lot of academic evidence, scholarly evidence, that clinical decision supports as they relate to behavioral health have the impact that that seem to be that they're driving for with clinical decision supports. So why are we going to talk about where does the specifics of reporting and data come from? Well, in a specific section of the Mental Health Act, the language includes reporting of encounter data, clinical outcomes data, quality data, and such other data as the Secretary requires. Based on this sentence, a group of quality measures was identified for the CCBHCs and the states as requirements and or suggestions for showing the quality of the services being provided, that you're meeting the quality expectations, you're meeting the outcome expectations. The first set of quality measures that we're going to talk about, and rather briefly, are administrative quality measures. I refer to them as that, but also does SAMHSA and CMS. And these are what is the time frames for providing services and other elements like that. As an example, emergency services have to be provided immediately, hence the 24/7 crisis services that have to be provided. Urgent must be done in 1 business day, and routine within 10 business days. A comprehensive person-centered and family-centered treatment plan has to be provided within 60 days of the first request for services. And then outpatient clinical services for established customers must be provided within 10 days of requested date. And you'll see this around. The difference between an established consumer and a new consumer appears to be whether or not I've received services in the last 6 months. And then we all know that readmission, hospital readmission, is a critical component of care, both at the state level and at the federal level. The requirement within CCBHCs is that CCBHC will attempt to contact all consumers who are discharged from hospitals within 24 hours of discharge. When it says attempt, when the rule says attempt, it doesn't mean that, it doesn't give an out to the CCBHC. The attempt is really based on whether or not the consumer has a means to be contacted. So if one of your clients goes into the hospital and they and their phone isn't working or they don't have it, or they don't have a phone, you can show reasonable attempts, however it is you currently contact them, but you may not be able to reach them in 24 hours. But that's not an excuse or not a means for the agency to not try within those 24 hours. It really has to do with whether or not the client can receive the contact or will receive the contact. The next thing that I find interesting about this, and I wanted to share, is the use of assessments within CCBHC. I'd like you to remember right now that I said that this is one of the first times that the federal government has really come out and said, here's how we think across the country you need to practice by identifying these elements. So one of the things they've done is, in certain instances, they've identified specific assessments that must be used, and in other instances, they've identified a group of assessments that you can choose from, and then in the third group, they've left it to your decision. What documents do you want? What assessments do you want to do? And so if we look at this list, it shows that diagnostic assessments such as mental status exams or biopsychosocial, those can be left to the CCBHC or the state to define. There is no single standard. Depression screening, on the other hand, this is the items that are identified on this list is the grouping of recommended assessments for this. I've seen some states choose a specific one, so maybe a PHQ-9. They have the right to do that as they put their proposals together. But the federal government has said that we are going to expect that you do a depression screening, but we will accept a depression, the results of a depression screening if you use one of these identified assessment tools. Alcohol screening, they've expressly identified the assessment to be used to determine if there is if for alcohol use or for alcohol issues, and that is the audit form. And that, if you're not familiar with it, came from the World Health Organization, and it is the only assessment. Now, you may use other assessments, but as far as the quality measures are concerned, they are looking for the results of the audit assessment. And then such things as assessment of imminent risk, you can use your own. Either the state may allow the CCBH to determine it, or the state may determine what kind of assessment they would expect you to use there. And then finally, what's called experience of care, but can also be translated to client satisfaction, client outcome. There are only two tools that you are being directed to use. For adults, it's the MISIP, and for youth and families, it's the YSS-F. And those are specifically identified, and the results of those are part of the outcomes that have to be tracked for meaningful use. So now what I want to do is go through these quality measures, because it's important for you to understand what they are as you make a decision, if you're not a CCBHC, as to how you're going to address them. We'll talk a bit about why you might want to once we go through them, and then talk about some of the things that brings up for the practice of behavioral health outside of CCBHCs. So the first is the number and percent of new clients requesting services who were determined to need routine care. Again, new is any client that you haven't seen in 6 months. So if I saw a client 7 months ago, and then they call again today, that client, for the purposes of this measure, is determined to be a new client. The next is the number and percent of new clients who had an initial evaluation provided within 10 business days, as opposed to the mean number or average number of days until the initial evaluation. Again, remember, these aren't necessarily new in a sort of a generic definition, but these are folks who have not been seen for at least 6 months. The next is the mean number of days before the comprehensive person-centered and family-centered treatment plan evaluation. Now remember, it doesn't say here that it has to be done in 60 days, but the CCBHC regulations specifically state for CCBHCs that they have to do that within 60 days. So this measure is going to look and say, well, what is the average day? You can assume that if it's below 60 days, that's going to give them, that will assure them that they meet that requirement, and it's above, it would likely require some sort of correction plan. The next is the number of suicide deaths by patients engaged in behavioral health treatment. I think that one sort of, and this is folks being treated by your agency. There are other requirements for people who are being treated outside of your agency. See, hold on, just went too far. 1 second. The next is the documentation of current medications in the medical records. Very much tied to meaningful use. You do recall that one of the requirements is that folks who are CCBHCs, and in general agencies are expected these days to use e-prescribing. This is just going to document current medications with probably an underlying goal to make sure that those medications, as we look at them, were actually prescribed electronically. The next is preventive care and screening based on body mass index. So this is part of those, these are the kinds of screening and then follow-up are those directly related to a BMI that perhaps has overweight or very overweight. But the idea here isn't just behavioral health screening. This is also, did the person receive dietary help? Did they speak to a dietitian? Did they get the kind of other kind of care that may go with an elevated BMI? So think again of the coordinated care, think again of a wide variety of services, and think that CCBHCs can't just hide behind the services that are expressly identified within the set of services, but also have to do what's ever required to meet the goals and the objectives there. And then weight assessment and counseling for nutrition, physical activity for children and adolescents. Again, we're talking about services that probably haven't historically been done in behavioral health agencies, but the need to bring that into it. And the next one is equally so, controlling high blood pressure. Controlling high blood pressure is a mixture of perhaps medication and nutrition and perhaps behavioral health services. But all of that is now could be on the head of the CCBHC to manage that, to make sure that's happening, to make sure by managing that care and overseeing that care that there is some relationship to what the CCBHC does and what that requirement is going to require. And then the tobacco use screening and cessation intervention. Now this is something that is also in meaningful use, may very well be a behavioral health service, but it's something now that to the extent that you were required to manage it in meaningful use if you were getting certified was one level, but now now you have another quality measure tied to it that is really part of this process. The next is the unhealthy alcohol use screening and brief counseling. This is the use of the audit screening tool to determine if there's unhealthy screening and then to provide screening and brief counseling. A child and adolescent major depressive disorder suicide risk assessment. What this is saying is that if you, depending on the ICD-10 or DSM-5 diagnosis, then a suicide risk assessment has to be done. And it's looking at the group, your group that CCBHCs are going to have to handle all age groups. So in this population, when that particular diagnosis occurred, was a suicide risk assessment done? Really a directed type of practice of what services should be provided. And then the same for adults. For clinical depression, the next one for adults was a follow-up plan provided. So what are the follow-up steps? Sort of similar to what medical providers might provide in the instance if somebody has a heart attack or such thing. And then remission at 12 months. This is really looking at depression being something that is can be resolved, something that is cured, not something that is an ongoing journey, let's say. So they're really specifically looking if somebody was depressed and then the diagnosis was ruled out, is there a remission within 12 months? Now the next set of measures are really state measures that behavioral health centers might be required to provide data to support but that the federal government is going to look for states to to report out on these. The first is a housing status. Now, I know in most systems, most folks can collect this information. It's not a requirement that it's collected, but it can be collected. Now it's moving into a required that you really have to identify what the housing status is of your clients. And it's really going to be, I think, over time, housing over time. If somebody is homeless, what's the time frame by which they become, that they get there's a change in their living status. The next element is suicide attempts requiring medical services. This is different from the last one because this is really where medical services required because of the suicide attempt. This is something that the CCBHC or your agency may not know, but the state is required to know from the various reporting hospitals do. Follow-up after discharge from after a visit for mental illness. Now, follow-up for you folks will include an outpatient visit or intensive outpatient encounter or partial hospitalization. And then the same for an emergency department visit for alcohol or other dependents. And you see that the same same services are identified. Now, the goal here is, I believe, to see that this is occurring and then to come back in and say, okay, now what can we do ahead of that emergency department visit to stop it? Again, how do we keep people out of emergency departments and put them into less intensive, less costly services? We can't, by finding out what these numbers are, we then can put in additional quality measures to ensure that that's what's going to happen. The next is the all-cause readmission rate. This really means how many, and this is probably familiar to many of you, what is the number of acute inpatient stays followed by an unplanned acute remission. Now, this is across all continuums of care, but the specific here that SAMHSA and CMS are looking at are acute inpatient stays related from either drug or drug issues or mental health issues. Diabetes screening for people with schizophrenia or bipolar disorder using antipsychotic medications. I suspect historically this has been done in conjunction with physical health doctors who could work with a psychopharmacologist or a behavioral health agency. But now the onus is on the behavioral health agency to ensure that this kind of screening is done, and to be able to make the lab orders, to read those lab orders, to act upon those lab orders when they come back and understand them. Again, this may be a new skill set for some of the folks in a behavioral health agency to be looking at this kind of these types of diagnoses. The next is metabolic monitoring for children and adolescents. Now, this one I would suspect that many psychiatrists and others who do who prescribe these types of drugs are already making sure that this metabolic monitoring is going on. But to the extent that isn't being done, it is now something that must be done, and agencies are required to do it. Cardiovascular monitoring for people with cardiovascular disease and schizophrenia. Again, either this is done in concert with a with a doctor, with their primary physician, let's say, or the CCBHCs are going to have the ability to both understand the diagnosis of cardiovascular disease and also take the steps necessary to monitor it. The next, adherence to mood stabilizers. Now, this is being judged by the number of prescriptions that are refilled, as well as other information that can be garnered from that process. But it is still an oversight that people are being asked to do to ensure a compliance to medication regimes for people with bipolar disorder. The same goes with people with schizophrenia. So if you think about it is not a hands-on, if there isn't an arm's length, this isn't, and it may never have been in your agency, but it can't be an arm's length prescribing where you throw a prescription to a pharmacy, they give it, and then unless the person comes back in, you're not going to understand whether there's an adherence to it. You have to know that they picked it up. You have to know that they got their next, they refilled it in a timely fashion. Sorry. Wait, I'll go back. The next is follow-up after hospitalization for adults. And again, what follow-up is defined as are these elements, same as before. And then you have follow-up for hospitalization for mental illness for children, the same concept of what's required for that follow-up. It is reasonable to believe that the goal in this is to help agencies see that by having this follow-up, had that been done in advance, perhaps the emergency visit or the hospitalization wouldn't have been necessary. But what's being tried here is how can we identify what causes hospitalization so that we can then reduce hospitalization. And these are ways that the quality measures are getting at that data to then, in a quality improvement manner, come back around and say, now that we know this, here's what we can implement. Follow-up care for children prescribed ADHD medication. And this means 3 follow-up visits within 10 months and 1 visit within 30 days. Managing of antidepressant medication, the same kind of idea. How often is the person seen and over a time period so that there can be a responsiveness, we can ensure that people are taking their medications and that the medications are doing what's necessary. And finally, initiation and engagement of alcohol and other drug dependence treatment. This makes perfect sense because, as I indicated earlier, the CCBHCs are responsible for providing the whole continuum of services for both mental health and substance abuse. And then finally, as I indicated before, there are 2 outcomes measures for clinicals to show satisfaction. One for the patient experience or adult, and then one for the youth and family. And these have to be done somewhere on the order of every 6 months or so by your clients. So a good question would come up now, other than spending a half an hour, why are there quality measures? What is the goal of them? Why do we see them? And why, if you're not a CCBHC, should you even really be concerned with them? And I saw this, I think this quote kind of helps as to what is behind this for CMS and SAMHSA, that a country with high healthcare costs, with poorer than expected health outcomes relative to other parts of the world, CMS is challenged to identify the best and most efficient means by which to improve care, with care still being patient-centered. Because CMS it has to look at this on a sort of a holistic way. It can't look at individual care. Also, so much of this was started, and we'll talk about this again in a little bit, so much of even the concept of quality outcomes started with physical health, then moved to chronic health, chronic illness, now is in behavioral health. And if the presumption is that those 3 areas are aligned, then perhaps this makes perfect sense. But if that presumption isn't supported by the reality, then we have to be not skeptical, but we have to question the outcome measures to ensure that they're doing what they want to do without a cost that is higher than it should be for the process that we're implementing. The other reason we have quality measures is because, as many of you, if not all of you, have heard, we as a healthcare system are moving away from fee-for-service. As we move away from fee-for-service, one of the major elements that's being added to the calculation of costs and the reimbursement of costs is the concept of quality. So in fee-for-service, there was probably no link to quality. But as we move from fee-for-service, the first step is we'll have fee-for-service with a link to quality, either the absence of quality or the existence of it. So there could be, just because it says a link to quality, it could be that the absence of quality measures could cause a reduction, whereas meeting quality measures could rise to an extra amount for reimbursement. And then we have alternative payment models that were sort of built on fee-for-service architecture, but go beyond it, bringing in the concept of both quality and risk. And then finally, we're looking at population-based payment, where payment is not service-based, but care over time. The prospective payments in CCBHC is that concept, where CCBHCs will be reimbursed for care given over some frame of time, a month, a week. So it's not just what service are you providing, but it's sort of what is the group, what is the care that you are providing. So if quality measures are going to be this important, I thought it would be a good idea to look at sort of what is behind quality measures. How did they come to be? So the National Quality Forum and CMS both came out with a quality strategy. And in here, I think, some of the things we've seen, you'll see these in the quality measures that we talked about, but you'll also, there are words that are widely used these days, and you can decide how they apply to behavioral health. The National Quality Forum's principles are to make care safer, to strengthen person and family engagement, read person-centered care, to promote effective communication and coordination of care, that there is an ongoing concept of quality across the continuum of geography and financial level and education, etc. To promote effective prevention and treatment, to work with communities to promote best practices, and to make care affordable. CMS has similar, but they start with three aims that are actually shared by both: better care, smarter spending, and healthier people. And then their domains are, as you see here, very similar. Effectiveness, the efficient use of resources, care coordination. You see these not just within the quality standards, but they also speak to what we started with, which what were some of the goals of the Excellence in Mental Health Act. These are elements that get repeated across all areas of care. So now a little bit about how these measures are defined. The first step is classification. If I want to bring a new measure to NCQA, to any entity that can put out a measure, it has to speak to process, access, outcome, structure, or patient experience. So I have to put it in one of those domains. I have to explain that my quality measure is really part of this domain. And then it has to be within one of the settings you see here. I put all these here because they're somewhere around the area of 30 different settings, of which one is behavioral health care. So you're going to get quality measures that go well beyond the concept of behavioral health care or substance use treatment, another one. And yet they're going to be brought back too. So I may get a care that says that I need to do BMI, I need to do I need to provide a dietitian and other nutritional information for somebody whose BMI is outside the norm. That started to be an ambulatory office-based care item. But as we went into the Excellence in Mental Health Act, as SAMHSA looked at health measures, they brought it into the behavioral health world. So not every item that is identified as a key quality measure by SAMHSA was designed for behavioral health, but more importantly was the scientific data that was used to prove it. Did it involve behavioral health clients? So principles for measure development. We know that we have to be in a domain. We know that it has to be within one of the settings. But these are the principles that CMS will look at to determine if the quality measure meets the requirements. So the first is, does it align with the goals and objectives? Is it a gap? And that really says, do we already have a quality measure that addresses this, or is there a gap in the way we've looked at things, so we need to fill that gap? Is there a business case that supports it? Here is important. Patient and caregiver input is equally important to provider input. That's great, but what if the measure is being applied in behavioral health but was really designed for physical health? Then the folks who are affected by it may not have been in the design, may not have been considered in the development. The goal is to get them rapid cycle, but we'll talk a little bit about that. People should work in concert with others, not independently or in a vacuum. There needs to be a transition away from setting-specific narrow snapshots. So you can't say in rural America I need to do X. There has to be more generic, more general, population-based quality measures. There is a goal to start, as they re-look at quality measures, to reorient them to a patient-centered outcome. So there may be different versions. But there's a continuous quality improvement process that goes along with quality measures, and that's going to be part of that gets looked at. Develop measures meaningful to patients, disparities, and unintended consequences. So you can see that there are several measures, sort of the goals of what measures. And this is the measure development life cycle. And I put this here so you understand not only is there a rigorous process for the development of measures, but it takes a fair amount of time, close to 27 months on average. Now there is an expedited way, but most measures go through a process that is going to take about 27 months by the time they bring in the people, the review is done for gaps, the scientific evidence is collected, people are brought into the system. So it is a long and arduous process that is going to cause a delay between the time something is thought of and the time that it actually becomes a quality measure. The technical expert panel is designed to include consumers, family members, others who have insight into the quality measure being discussed. It also is supposed to reflect geographic and organizational diversity, so that because a single quality measure is going to be applied in all geographic areas of the United States. So you have to be able to understand the differences that may occur because of geographic differences, because of socioeconomic differences, because they're not looking to have 3 different standards. They're looking for a single standard that will ensure a sense of quality that goes through, that is equal in New York City to rural New Hampshire, to Los Angeles, to wherever the client may be. Person and family engagement is important. these quality measures are supposed to include and be inclusive of people who are really going to have to be tied to these measures. So there is a need to have a broad base of involvement of family members for family engagement. And it's asking a lot of the people involved, because these are scientific measures that you're bringing people, clients and family members in to talk about, to vet, to review. And it's a challenging process, but it is an important process, because in a person-centered world, you need to bring the people that these are supposed to be centered on into the process. And there is a goal to do that, and it is something that is of more and more import to the folks to these designing bodies who are involved in the process. So now we've talked about the CCBHCs, the quality measures, and how they're designed. For the last few minutes, I want to go over some of the questions that come into my mind as we look at these items. The first is, and this is really, are these opportunities or challenges? Do they improve quality of care, or do they challenge quality of care because of the inordinate restraint they put on behavioral health agencies? I don't mean to say that one answer is correct, and I don't mean to say that there really is an answer, but these are the questions that I look at when I talk to people about which quality measures to implement, how to look at quality measures. The first one, quality measure development is supposed to be inclusive of public input and representative of diverse geographic and socioeconomic backgrounds. Do they really, or should they really, ensure a level playing field across the country? Is it right to assume that the quality, the practice within an agency that leads to the quality outcomes is going to be the same across diverse areas of the country? Diverse because of the availability of practitioners, diverse because of the perhaps cultural differences that may affect how care is provided? Or is it unreasonable that it isn't a level playing field? Is it unreasonable that we should think that the care provided in rural New Hampshire should be exactly to the same levels, to the same quality level as in Palo Alto, California? And where does the balance lay between those two? As a person who's lived in both Northern California and rural New Hampshire, I might expect that the quality of care that I receive or my kids receive shouldn't change based on my location. But I also might know that that's a little impractical because of the differences in the cultural differences, the ones I've said before. So how should these quality measures affect this particular element? Then there's a concept of quality measures were often, as I've said a couple of times, medically based. That's where they came from. And medical is often solution or cure based. You go with a strep throat and you expect to be cured when you get when you are given antibiotics. But mental health, especially for the seriously mentally ill, is a journey. We don't talk about solution or cure based. We talk about the improving of life, the giving people the tools to live their life in a way that is comfortable and is life affirming. Person-centered. Can we improve your quality of life? We don't tell somebody you're seriously mentally ill and we can fix that. But is that what quality measures are really trying to do? Do we really need, or perhaps do we need, a new paradigm for quality in behavioral health? A paradigm that focuses on the concept of journey, the concept of learning to live with, I may learn to live with my addiction. I'm not going to cure my addiction. I'm going to learn to live with my mental illness. I can't look for a cure, but is there a paradigm that shows that I am learning to live with it? Is the only paradigm that is there whether or not I take my meds? I'd like to think that in the world of the kind of research that's done, that there's a broader concept that could be looked at and perhaps brought into quality measures. We know that quality measures are standards for the new payment methodologies. Do they also define how to practice? Is there some sort of implicit, this is how you're going to deal with depression? This is how you're going to deal with, well, let's leave depression. I know there are practices in this country who try very hard in their practice to move away from medications towards other kinds of therapy. Is that practice, will that practice actually meet the quality goals that are identified here? And if it won't, do these quality goals impact really how behavioral health is practiced? In a very unartful way, I say, do quality measures require that behavioral health practitioners teach to the test, or are they really practicing their expertise and the test is just what comes from that? The next question sort of follows along the same lines. If quality measures take 27 months to develop, if quality measures really focus, if you really have to define your practice according to what those quality measures would expect to defined outcomes, does this mean we are inhibiting or limiting changes to clinical processes? The next person who comes up with the next new theory of how to treat depression, are they going to be implicitly stopped from moving forward because they're not going to be reimbursed because they can't, the quality that they're bringing to their clients isn't the same quality that's defined by the CMS guidelines? Mm-hmm. And if so, go back to the new paradigm. Do we need to think outside the box and come up with a new paradigm in defining what behavioral health quality measures need to look like? Finally, to sum it all up, quality measures provide a standardized set of measures that together define what CMS has decided is best practice. Does that limit or completely stop the freedom of choice that I want my providers to do in clinical methodology? And if it doesn't today, is there a risk that it will as Medicaid, as Medicare moves towards a prospective payment and Medicare follows suit, and as that happens, so does private insurance perhaps? Do we need again to look at these measures as things that look at measures not as what will ensure payment, but I do understand the importance of that, but really, do they or don't they ensure a quality outcome for my clients? Does this make a difference in the life of my clients in a person-centered world? Does person-centered conflict with standardized quality measures? My goal today was to give you guys something to think about. I know these quality measures are coming down towards, if you don't have them already, they are things that are coming your way. But as you implement them, as your agencies look to implement them, whether you're a CCBHC or a behavioral health agency that really just needs to move into the new, needs to move towards these items as they become part of your reimbursement methodology. I hope to sort of give you an idea of where the challenge is and what are some of the things that can be done to meet those challenges, what are the questions that can be asked, and begin a group discussion of how these might change if in fact change is necessary. So with that, I'll thank you all very much and hand it back to questions.
Thank you, Suki, for that very informative presentation. We'll now open up the session for a brief question and answer period. If you have a question, please use the question box on the GoToWebinar panel so our presenters can address the questions. We'll try to answer as many questions as possible, but if we don't get to all your questions, it'll be answered as a one-to-one basis after the broadcast. As a reminder, all participants will receive an email in the next few days containing the link which will allow you to download a PDF copy of the presentation and listen to a video file of today's presentation. So I'll allow like a minute here for everyone to ask their questions. So we'll hold until we can get our first question. Okay, so we have a question. How do you advise providers to track medication adherence without prescription fill data?
It would have to be done by really just a question, really two ways. If the provider is responsible for creating the prescription, then they may not know what was filled, but there is going to be some interplay with the pharmacy as to whether or not they can, how often is one asked for, will the pharmacy take it or not. Secondly, it's going to have to be done through the counseling process, through talking to the clients and making sure, and talking to them and seeing, working with your clients who you know as to whether or not they're getting their meds, that they're taking their meds. And in some instances, you're going to know too because there are blood tests that go with those and other kinds of tests. But it is going to be difficult. In an electronic prescribing system, though, you should be able to, one, send your prescription electronically and get an indication back from the pharmacy. They will have fill information that they can provide you.
Okay, well, it looks like we're about out of time, but thank you all for joining us for Treating for Outcomes or Better Care, Understanding and Using the CCBHC Process to Manage Organizational Quality, brought to you by the Echo Group and Open Minds. Thank you to our presenters, Norris, for joining us today, and to our audience for attending this session. Have a wonderful day.